right, awesome. Well, ready to get started. Hello, everybody. If you're joining us new or rejoining from earlier on, welcome back. Afternoon sessions. My name is Alex. I'm a first year neuroscience PhD student at Yale. Some housekeeping. This session will last 30 minutes. First 20 minutes will be the presentation, followed by 5 to 10 minutes of Q&A. Participants will only be able to interact through the Whova chat and Q&A function. We've disabled the unmuting and hand raising features just to sort of avoid virtual disruptions to presenters. Virtual conferences are always hard in that way. But rest assured, the presenters and our conference team will have access to your questions and your comments, and they will be shared. So with that being said, I'm very excited to introduce Reim Ifrach. So take it away.
Sure. Thank you so much, Alex. So my name is Em. I am a clinical art therapist and eating disorder specialist, and today I'm here to talk about body ethics, weight neutrality, and clinical work, specifically with trans and gender nonconforming clients. So my hope for our time together is to learn how to talk about and implement a gender neutral, weight neutral approach, how to ethically affirm trans and gender nonconforming clients of all body sizes, especially when facing medical fat phobia, to cultivate a strong sense of empathy and understanding for trans and gender nonconforming folks' lived experiences, and to cultivate the integration of a little bit of experiential learning that can aid in embodiment for clients and mirror mindfulness work in your work with those clients. So basic introduction, based on the research of many people, including Taylor, Tribole, Dizelle, Protos, and Gay, we see the need for weight neutral approach in clinical work as a way to mitigate risk factors, including eating disorder development, the development of low self-esteem, and continued distorted thinking about the body. It's really cool when you see the last 5 minutes of someone else's presentation and you're like, yeah, weight neutrality, exciting. So I think like what was being said in the presentation before this one, it's about taking an approach where we're seeing people as a whole person and not just as a BMI number or the number on a scale. So the risks to a lot of this include the rising statistics of the development of eating disorders within the trans and gender nonconforming community, where currently it's actually 50 to 70% more likely that any of them would develop an eating disorder. That statistic went from 50 to 70% during the pandemic in the most recent survey by the Trevor Project. These risks are further exacerbated by systemic fat phobia, transphobia, healthism, and the use of weight as a barrier to accessing life-saving treatment, including gender-affirming medicine. A weight neutral approach involves promoting health enhancements, eating for well-being, holding respectful care, incorporating life-enhancing movement, and being weight inclusive in a client's care. So in embracing this, we embrace the ethical principle across all fields of do no harm by addressing a client's deeper connection and concerns of their body, especially of those who present in a marginalized or oppressed body that often face systemic barriers and discrimination. In a weight neutral approach, we don't enable unhealthy behaviors. We look at systemic barriers and how lack of access to resources creates further negative relationships with the body, with gender identity, and continues to be a struggle for our clients. So the first thing here in a weight neutral approach is actually every time you meet a trans and gender nonconforming client, you should be assessing them for an eating disorder, regardless of what your discipline is. So whether you're a doctor, a psychiatrist, a therapist, if you're a part of their care team, this should be something that we do from the beginning. And the truth is, clinically right now, unless someone else has a new assessment they can share with me, there's no really good screeners for eating disorders. The reason being most are self-assessments, and they leave some important gaps. However, they can be good kind of tools to have in an intake packet or to open up the discussion with your client. It's really important to note here that of these assessments listed, I've been trained to use all of them. I've used all of them with my clients, and lived experience. I've taken all of them and can easily fool anybody on all of them as a client. And so that's why I kind of say there's not a good screener, because if the screener, it relies on my self-report as someone with potentially an eating disorder, you're not always going to get the answers that you need. But these assessments include the eating disorder quality of life, the body shape questionnaire, the binge eating disorder 7 question assessment, the eating disorder examination questionnaire, and I prefer the EDQOL in general. The other thing to note here is a lot of them can have very gendered or binary language. So often when I use these with my clients, I edit them and just use them for my own clinical purposes rather than using the entire assessment. And again, highlighting the importance of assessment because we don't really know when we see a body what they're going through, but you can assume if you're meeting a trans or gender nonconforming client that statistically, if 2 are in the room, 1 of them is going to have an eating disorder. So I actually like to ask clients a multitude of questions to gauge if one is present first and the severity before we kind of move forward with the approach that we would take for this. So I ask clients a lot of questions about what they eat, how do they feel about their body, do they work out, do they count calories to change their body? Have you ever been on a diet? Which, I mean, if anyone ever tells you they've not been on a diet, I really do not believe them at this stage of the game. If they like their body and if they could change something about their body, what would it be? And those last 2 questions for these clients are super important, right? Because liking your body when you're cisgendered and therefore in a body that is congruent with how you feel as a person is vastly different when you say yes than someone who may say yes or they're not sure when they're questioning their gender or they know that they're trans or gender nonconforming. And often the things that they would ask to change have deeper meaning. So I am a non-binary genderqueer person, and I might at some point of time in my life have said that I would want to change the fact that I thought I had a fat stomach, because what I really couldn't label for people as a fat stomach meant wider hips, which meant you could code me as being assigned female at birth. And that was uncomfortable at that time. So it's really diving in deep to figure out what's going on and kind of knowing that there's probably an eating disorder or at least disordered eating going on underneath there. And that needs to be included in this approach. So medical fat phobia and systemic barriers are some of the biggest that our clients face. And we know that fat phobia specifically has direct ties to racism. I highlight this because many trans and gender nonconforming folks have intersecting marginalized identities like being BIPOC or AAPI. So in Dr. Sabrina String's book, Fearing the Black Body, The Racial Origins of Fat Phobia, which I highly recommend, she discusses how fat phobia was a direct response from white women who owned slaves and felt threatened by the way African women were often sexualized and prized by white men behind closed doors. She highlights that Black bodies were enslaved, working in the sun, generally having more muscular, curvy bodies, a stark difference from the waifish white women who sat in parlors all day. And this led to the sexualization of specific body parts, body presentation, and skin colors that are equally systemically abused. Again, highlighting this because many of our clients will come with those intersecting identities, and white supremacy affects all people, and especially those with marginalized identities. And many trans people face the same kind of sexualization and fetishization. So furthermore, she asserts that the religious ideals of being pious, godly, and in control all became about body size. Fat meant out of control, sexually devious, ungodly, and immoral. It was during slavery that fat became synonymous with morality or lack thereof. And this has created a long history of religion and body standards being weaponized against themselves. This feels like a really timely time to kind of bring up this topic, and it was not done intentionally. Clients that are trans and gender nonconforming that are coming to us for treatment and wanting to work on their bodies also have to face that same long history of religion and body standards, and religion and body standards being weaponized against them. On one hand, they'll hear that they are, you know, not godly enough because they do not identify as being cisgendered. That on the other hand, if your body is too big or too something, or you present to one gender or another, there's something wrong. And so a lot of this is to set the stage for the fact that when you meet a trans or a gender nonconforming person, you have to assume that there is deep-seated internalization of all of this history within them, and that just to come to us and talk about their bodies is kind of a really big deal. So, weight neutral approach with our gender diverse clients. So, body liberation is the framework that I use for this, and body liberation is the freedom from social and political systems of oppression that designate certain bodies are more worthy, healthy, and desirable than others. Body liberation interrupts our systemic oppression of bodies and allows clients who live in bodies outside of the social norm. We're talking about gender diverse clients such as trans and gender nonconforming, but I will always highlight that the same can be said for BIPOC, AAPI, disabled, neurodivergent, any other kind of body that doesn't fit into what we consider a social cultural norm, right? And these are bodies that are asking to be seen and heard and experience being valued and valuing having a physical form. And so therefore, right, body liberation also offers our clients a chance to directly address the systemic barriers in their own treatment. And this is the most important part, right? When we're talking with someone about their body, we're not just going to talk about their weight or what they're eating or how they're exercising. They can go to a CBT specialist for that, and they can do thoughts, feelings, behaviors. Great. There's so much more for this for our gender diverse clients, right? For them, there's that whole socio-political history, there's family history, there's the medical barriers of if your BMI or your weight isn't a certain place, you're going to be told you can't access certain surgeries, which, by the way, is not actually always true. I am in a much bigger body and was able to have top surgery in a healthy and safe way because I had a team that took a weight neutral approach and valued me and my liberation from our system above all things, which is why I'm here and why I know that this is possible. And so really what this offers our clients is the ability to be the agents of their own change and finally be in charge of a body that the world would like them to not be in charge of. So the Center for Health and Wellbeing at the University of Vermont are actually some great champions for body liberation in particular, and they actually use it in a lot of their education, which is great. And again, they say that body liberation is the freedom from social and political systems of oppression that designate certain bodies as more worthy, healthy, and desirable than others. We do not believe that bodies that are white, able-bodied, cisgender, thin, or fit are superior, worthier, or inherently healthier than any other bodies. We use a social justice lens to approach body politics and body liberation. Forms of biases and prejudice that impact health and well-being can be structurally systemic, interpersonal, and internalized. And their examples are the ones that our clients actually face the most in my work. So ableism, right, the discrimination and prejudice against people with disabilities that favor people who are considered able-bodied. Sizeism and fat phobia, right, the discrimination and prejudice against people who are fat, overweight, and obese. And healthism, the discrimination and prejudice against people who do not prioritize health and fitness above all else. So when I work with my clients, this is actually the lens that I bring them. I actually bring them this exact slide when they kind of walk into the door. And I say, you know, this is what I want to do with you. Here's why. Here's all the systems that I understand. What is your systemic experience in your body, in the world? And what do you want to gain out of your experience within your own body? And that question feels really important when right now in particular, there are so many laws about trans and gender nonconforming bodies, what people can do to their bodies, what they can't do to their bodies, what they can access, in what ways they can be accessed. And so when I present this to my clients, I present to them the fact that, you know, I kind of do the thing that I signed up to do when I became a therapist personally, which is to walk into spaces where people do not feel heard, do not feel loved, do not feel empathized with, and are often kind of rejected from a system that often benefits off of those people's rejections and create a safe place in the world for them. So the weight neutral approach with these clients involves all of these things, and these are all the things we talk about, right? So we talk about how health, right, is a core value for all people, whether we want to escape healthism or not. And physical, emotional, mental, all of that health is important. So we look at health as being the center word that we deal with, and then we break it all apart, right? So it's not just looking at how to be weight neutral, as in not talking about BMI and not talking about weight, but it's looking at, are you comfortable and happy with your diet, right? The way that you eat, the food you have access to, and the resources that you have to do with that food what you want. Do you have safe, stable, regular places for exercise, for moving your body, and for being in your body in ways that promote you feeling good about yourself? Do you feel like you have the emotional support you need from your team and from the people around you? What are your resources when you're in emotional distress? Do you feel like you have a good social life, right? Again, the resources of people around you, your connection to spirituality. Do you feel like you need or want a spiritual community? Do you feel like you're intellectually engaged in the ways in which you want in the world? How's your general environment where you live? And occupationally isn't just what's your career, what work do you do, but what do you put into the world that matters to you, that feels like it's your calling? And it might feel like none of these actually have to do with this approach, but for me, this is the center of that approach, because a weight neutral approach is actually about taking weight out of the conversation and asking us to look at all the other markers of what makes a human being themselves, right? And focusing on how do we promote that person being the best version of themselves based on who they tell us they are and who they want to be in the world. So again, like I've said, right, this isn't about weight in terms of numbers. It's not about BMI. And so the weight neutral approach not only doesn't use BMI, but it actually educates our clients on the BMI so that they can start to unlearn those internalized biases and also ask their providers to avoid conversations in which this would be present, right? So I have the chart for the BMI up here because I always point out to people that if you notice, more than half of the chart would be obese. Only a small section of the chart is green, right? Normal. And so like, there's no way that human beings work like that. But we know that the BMI is actually not an evidence-based medical tool, and it wasn't created for weight management. It was originally created by a French astronomer for the King of France, who wanted to look at poverty levels across a small section of their population. It was created on thin, cis, hetero, white male bodies of richer class, and the creator of the BMI himself is documented as saying that it is not for weight or weight management of any kind, right? This is not what this tool is used for, and our medical systems are kind of forced through insurance to use those tools, and it's been a large part of our training. And as an eating disorder professional, it was actually a large part of my training in assessing and doing diagnostics, and it's not something that I use anymore. Because when I remove these systemic barriers, I saw people get better. I saw people accessing the care that they needed. I saw people actually liking themselves, right? Having good relationships with their body, with their gender identity, and with their queerness. And that felt more important to me than whether or not they fit into this little green section right here. So some experiential approaches, right, as we're kind of coming to the end of the talk so you can ask questions. That I encourage people to use as an art therapist, right? So these are things that any therapist of any discipline, any doctor, any psychiatrist can kind of use, and they feel really important. So body scanning, which is I use the outline of a person. I usually use this shape of a gingerbread person, and I ask people to show us where their emotions connect to their bodies, and we color code their feelings and we place them in their bodies, and we talk about what is the connection between their feelings about their bodies and where those feelings are held, right? And then it also kind of helps us figure out where symptom management also needs to be kind of attended to. And it gives you a really good idea of body image, especially when clients start blacking out big parts of their body or telling you they're not connected to something. So grounding techniques like doodling in a mandala to regulate when feeling disconnected can be really helpful. I actually use, when I'm in person with clients, 6x6 paper on a wall, and we'll draw them a big mandala, and we'll do body size mandalas, because bilateral stimulation of movement with an art supply can actually help connect someone into their body so we can process what's going on. And then collaging is actually a safe way to explore body and explore gender without looking at one's own body. And it can give you a lot of really good, rich information about what's going on for that person in a really short period of time. In other talks, I would have been able to do those with you, but we have a short period of time, and I want to make sure we have time for questions rather than our making. So questions, and I can remove the slides if that would be helpful. That is my information for those of you that would like it.
Okay, that was wonderful. Thank you so much, first of all. We have one question so far, and again, please use like the Whova, or you can also use the Zoom chat, whatever is more comfortable. and then we can read out your questions for you. How did the BMI make its way into our medical system? Like what is the history of that?
Oh, you all think I know everything. Don't know. That is a really good question. I know it had to do with insurance, but I don't know if there's a specific doctor who decided that they felt it should be utilized that way, or how that practice kind of came to be standardized practice. Unfortunately, I'm a therapist and not a doctor.
Well, I do have another question then, which maybe you can answer, because that was yeah, definitely medical history is something that's very complex, and I think we need to read more about that. But we have another question here, which is, do you have any recommendations on how to discuss physical health implications like high cholesterol, diabetes, etc., in a more weight neutral way with patients?
Yeah, so I tell my clients that often, right, our discussion could come back to weight, but we're going to put that kind of in a box in the corner and discuss all of the other factors. So cholesterol and diabetes actually have genetic implications in research. So how many people in your family have it, right? Have we changed the way that you've eaten, right? Can we examine, do you eat a lot of high sugar and high cholesterol foods? And have we tried medication management before we try weight management? Often if we get cholesterol and diabetes under control, the weight naturally evens out to what's more that person's set weight point before food and exercise in our culture interrupted the way that body should be. And so I always encourage that first. And when we've tried everything else and nothing else is working, then we have the weight conversation as the absolute last piece. And I often do that where I actually join with their medical team and their psychiatric team, and we all have a group kind of treatment team discussion rather than one person in a room with a doctor in a gown, kind of feeling vulnerable, and having a discussion they've been avoiding for a really long time.
Yeah. I mean, I have a question. So I work in sexual health, and especially like thinking about contraception, you know, and especially the emergency contraception. How do you discuss something like emergency contraception? And for context, it said that the emergency contraception isn't effective in people who weigh above, I might be getting the number wrong here, 145, is it?
Yep.
I think like, yeah, pounds. And so like, it's almost as if a lot of people who are above a weight, particular weight, are often like excluded from important conversations or don't have enough access to emergency contraception, or doctors are very swift to say, if you lose weight, then you can go on emergency contraception. Is that something that you also discuss within your practice?
Yeah, especially with trans and gender nonconforming clients, there's always an overlap of sexual history. In fact, I've had clients that have done sex work where this needs to be a regular part of our conversation. So we talk about like three things. One, they are excluded from the conversation. And so we cannot rely on Plan B and other forms of emergency contraception as an answer. So we need to plan now for when that moment will happen and what that will look like. And then we talk about what are all of the options. And I mean, you will know more than anybody, right? Our sexual education is poor. I've had to explain dental dams and all sorts of things I did not know when I went to grad school. I would need to know or explain to people in detail without blushing. And I think I've learned really well. And so we have really good sexual education conversations around, if you have no plan B, literally, we need only plan A. And what does plan A look like for you, your body, and the people that you're having sex with?
Yeah, and I think that those conversations, like really thinking from a prevention public health standpoint, is just so much more important. And I think that's the work that you're doing is so important. I don't, maybe let me see if I think I have another question. It says I have two questions here. Just a quick second. How do you approach clients who are wanting to lose weight and also take a body neutral stance?
Oh, I love that. What people want to do with their body isn't actually my business. That's part of having a body neutral, weight neutral stance. So I offer to them that while I don't promote intentional weight loss, and I can offer them reasons as to why, if that's something that they want to do, I'm also not going to stop them, but I am going to ask them to engage in activities around how can they feel connected with their body in that process. I am not going to enable disordered behavior, and I'm going to pay attention to that, but I'm also not going to shame someone for wanting to change their body. And to be honest, as a fat person, of course you want to change your body. Like I want to change my body all of the time, because people will treat me better if my body is different. So sometimes it's also empathizing that people's motivation for stuff really deep down is just wanting to be liked and valid and having space. And when you don't feel liked or valid or like you have space, you're going to do things to get that to that place. And so if we can just start with that empathy and like letting that all be in the room together, everything else from there is honestly manageable, because our clients know we're coming from a place of actually caring about them and not about what their body looks like.
I love that so much. It reminds me of when Lizzo, took to the internet because she was trying to lose weight, but talks about, being a fat person and how people were vilifying her for wanting to lose weight. And she's like, that's my personal journey, and in a world that seeks to like vilify me, why can't I find happiness in wanting to lose weight? But it's funny how the body positive advocates were like taunting her for wanting to go on like a weight loss regimen. So yeah, I really wish, we had more therapists like you, Em.
Oh, thank you. I try.
Well, we've had such an amazing conference so far. What a way to close our day. We have one last session after this, and it is the only remaining session by one of our committee members, Mariah. So if you all have time, please come, and thank you once again, Em. This was awesome.
Thank you. Thank you all so much.
All right, we'll see you all.
Bye, everybody.
Bye, everybody.